it's 11:05, so we'll start, sir.
Sure.
So good morning, everyone. All the postgraduates, the faculty, very good morning. So this is in our series of NAOA PG teaching program. This is the 21st episode, and we have been doing both faculty classes and postgraduate classes. So 11 faculty classes till date, and 10 we have had interactive sessions of postgraduates. So today, speaker for today is, I'm really happy to introduce sir. So Professor of Orthopaedics at AMC, second unit KGH, Dr. Sivananda Patri sir. So he is my professor as well. Like many of you, even I had the privilege to train under him. So he is a totally an AMCite. So he has done his MBBS, MD Pulmonary Medicine, and he has then joined MS Orthopaedics, totally from AMC. So later again, he joined as Assistant Professor of Orthopaedics AMC. That is where we have been associated with sirs when we were postgraduates. Then he has transferred to RIMS Srikakulam as an Associate Professor. Later he became a professor there, and again now he has come back to his parent institution in the position of a professor. So he's a die-hard fan of academics and teaching. All of those who have been following him would be more aware, and he is a part of faculty of many PG groups as well. Trauma, arthroplasty, arthroscopy, and spine has been his areas of special interest. So he had done a proper fellowship of arthroscopy under Vijay Sagar sir from Global Hospitals, and arthroplasty under Surya Bhan at Delhi Private Super Specialty Hospital. He had an international fellow in spine surgery from Switzerland, from Dr. Thomas Foster. And this is his family, and sir dedicates its prioritized time to family as well. So madam has been a homemaker. Daughter is right now undergraduate at AMC, and his son is right now a BPC student aspiring to be a doctor soon. So his mentors have been the phenomenal C. Dharmarao sir and Dr. B. Uday Kumar sir, whom we all know. And this is when Uday Kumar sir shares a pleasant moment, warm moment with him. So this is Dr. Sivanand sir for you, my dear students. So let us proceed to examination of knee joint by Dr. Sivanand sir. And sir, we heartily welcome you to the 21st NAOA PG teaching class. Thank you, sir.
Thank you, Santosh.
Sir, you can start sharing your screen, sir. This will automatically stop. I have stopped anyways.
Good morning, Sivanand. Good morning, Khan.
Sir, good morning,
good morning,
sir.
Patil, sir.
Good morning, sir.
I am held up in a family function at Rajahmundry, but I will be joining you.
Sir, thank you,
All
sir.
the best, Sivanand.
Thank you, sir. Thank you very much, sir.
Share your screen, Sivanand.
Sir, I did it, sir.
Yeah, he is from Raviteja's account, sir. So that's why we are getting confused.
So, good morning, all my loving students and my respected teachers and esteemed faculty here, sir, my senior professors. And this talk is knee joint examination, and I am thankful to Professor Uday Kumar sir for giving this opportunity, and I am thankful to North Andhra Association and OSSAP, who has created this and is giving a lot of academics to the postgraduates as well as consultants. In fact, it is academics for the everybody, because academics, nobody can escape from the academics. Every day is a learning process. Every day is a learning process. So the knee joint examination, today's talk here, consists of first core basics. What is the anatomy and what is the functional anatomy? Then what are the disease process we will come across? We have to discuss about that in the differential diagnosis. And knee joint is nothing but all eccentricities. It is having all eccentricities and it is having an excellent function. Why I'm saying this word is, if you take the knee joint, it is not congruent like, it is a congruent, but irregularly it is, even though it is a irregularly anatomical shapes, still it is highly congruent and highly efficient function. It is not unlike a hip joint where it is a smooth ball and socket joint. Here you take the knee joint, if you take the medial condyle of the femur, the shape is different. Lateral condyle of the femur, the shape is different. And if you take the medial tibial condyle, the shape is different, and lateral tibial
Slide
condyle.
is not moving, Shivanand.
Sir.
Slide is not moving. Slide is not moving.
Sorry, sir. Now, so if you take this, so it is a complex hinge joint, and it is the largest hinge joint, and it is the largest synovial joint in the body, and it is surrounded by important ligamentous structures, and which is supported by the enormous, robust, energetic motor that is called quadriceps. In the knee joint, if the quadriceps is not there, then every function will be stopped. So quadriceps is the most important thing to stabilize the knee joint, and as well as it is further supported with the capsule and ligaments, the extra-articular ligaments and intra-articular ligaments. They are having a complex anatomical function that gives a enormous mobility as well as a stability. So in other words, the knee joint stability is totally dependent on the ligaments and a capsule and surrounding structures, which are posteromedial complex and posterolateral complex. These are called quadruples. Four structures are supporting on the medial side and 4 structures supporting on the lateral side. So these will give you the enormous stability to the knee joint. So without knowing anatomy, it is very difficult to understand what are the tests we are going to perform. So in this video, just I am showing something. So you see that it is a medial side, it is related with the collateral ligament, medial collateral ligament, and lateral side, it is lateral collateral ligament. And anteriorly, it is the quadriceps tendon and patella, which increases the excursion and the capacity of the quadriceps function. So the medial collateral ligament is restrained for valgus force, and the lateral collateral ligament is restrained for varus force. And if you see inside of the knee joint, as you see that, so inside there are 2 cruciate, they are crossed. So the anterior cruciate ligament is restrained for anterior translation, and the posterior cruciate ligament is restrained for posterior translation. It is not only it restricts the posterior translation of the tibia, it also restrains for the rotational component as well. ACL is a very important rotational restraint for medial rotation, and PCL is a very important restraint for lateral rotation. So that's why this is having internally also it is a very complex joint that is having this function. And knee joint movement is also a rollback. This thing you should know it. And for which that rollback function to functionate, the PCL is also very important. You see this, once the anterior cruciate ligament is translated, tibia is translating more on the anterior side. Then come to that, there is another movement is called, it is a screw home movement. Screw home movement is the very important function. If there is no screw home movement, then there won't be a locking mechanism of the knee joint. So without locking mechanism, the knee joint will go into the flexion, and in a flexion knee, it needs a lot of muscle power to get the function. So that's why to decrease the So you can see that in the screw home movement, the tibia is rotating laterally, external rotation. So once this function is predominantly by the quadriceps, this is called locking movement, and unlocking movement is produced by the popliteus muscle. So with this introduction, so what are the disease conditions that commonly you will come across for the knee joint proper? So here it is, simply remember that mnemonic, it is called CT medino. So CT medino means it is C means congenital, and T means traumatic and metabolic, inflammatory, idiopathic and degenerative and infective, neoplastic and neurovascular and others. So we must have a sufficient knowledge about all these conditions where they can produce any problem at the knee joint. Those things, those conditions, we must be very thorough in the theoretical aspect. Then only we can understand this. Indirectly, what I'm saying that what the mind doesn't know, eyes cannot see. Whatever problem is existed there, if we don't know that, we cannot see at that particular joint. So for the sake of congenital, it starts from the birth. So those things like congenital dislocation of the knee joint, for example. And traumatic thing can be divided into, it is a high violence injury and a direct injury and indirect injury. Direct injuries like dashboard injuries and indirect injuries like in the sports, there is a twisting injuries to the knee joint. And the metabolic problems very commonly we see just like rickets. Rickets is a very common metabolic problem commonly seen in the children, what we see. And inflammatory problems, it is a mostly it is because of rheumatoid arthritis and the seronegative arthropathy which can affect the knee joint. And those things we must know about that. And degenerative conditions is routinely osteoarthritis. And sometimes if that particular joint is repeatedly used and overused, then that joint will go for the degeneration of that particular joint. So infective, it affects all age groups. The degenerative problem affects in the older age group, inflammatory problem affects in the middle age group, and the metabolic problems can affect in all age groups, but especially in the children, it is metabolic problems. Traumatic can affect all the age groups, active age groups. So infective also can affect all the age groups from the childhood to in an elderly individual, it can affect. In infective, you have to differentiate whether it is an acute infection or it is a chronic infection. So acute infections like septic arthritis and sometimes osteomyelitis of the femur, osteomyelitis of the tibia, and chronic arthritis infections like tuberculosis. Tuberculosis starts with the synovium and that can affect the bones as well in these conditions. And neoplastic conditions. So neoplastic conditions commonly there are benign and malignant varieties there. Most common benign variety, it is the osteochondroma. Very commonly we will come across around the knee joint. And another benign condition in the middle age group, we will see that it is a 60% of the 60 to 70% of this tumor is around the knee joint. That is osteoclastoma, giant cell tumor. And neurovascular conditions like any neurological condition that affects the quadriceps muscle or like a polio that will affect the muscles, those can lead to the deformities in these particular patients. So you have to see for the neurovascular examination as well. And others like chondromalacia, patella, which is commonly seen in the females, and osteochondritis, it is in young individuals, epiphysitis in the growing phase of the child, we will see this. These are the other conditions what we come across commonly in this. When we take the examination, so examination should go in a proper manner. So haphazardly if we take it, then we will miss a proper diagnosis. We will miss the findings. So in examination, 60 to 70% of your examination goes for the history only. History only. Once you, after taking history, a student must be able to get the diagnosis. So only thing, the rest of the examination will give you the differentiation of other differential diagnosis, and additional investigations will confirm the diagnosis. That's why the history is the most crucial part in the examination of any joint. In other ways, but especially in the knee joint, it is much more important. And then we will do that inspection, palpation, movements, and measurements. And other most important thing is in the knee joint is special tests. Just like shoulder, it is also having many special tests. So every part has to be tested. But there are many tests, but you should know at least 1 or 2 tests that is more specific and more sensitive. This is the very important point. Those 2 tests, at least minimum 2 tests, that is more than enough. For the student, it is better to know that. And never forget neurovascular examination, because neurovascular examination can affect the quadriceps function, and vascular problems can lead to the pain in the knee joint, and some of the popliteal aneurysms are very common around the knee joint. So if you miss that, then it will be a disastrous. And other joint examination. So most of the times, the radiating pain from the hip joint to the knee joint is very common, like in a Perthes. Sometimes if the knee joint is absolutely normal in examination, but patient is complaining of severe pain there, then it is highly suggestive of you have to examine spine and you have to examine the hip joint. And any deformity in the knee joint, always you have to examine the hip joint as well as ankle joint. Why it is important means, in the hip joint, more anteversion will lead to the valgus deformity at the knee joint. And if the patient is having fixed calcaneus, equinus deformity, these patients are more prone to have the recurvatum at the knee joint. So any deformity at the knee joint, it is a rule of thumb, you must examine above and below. So let us start with the history. In the history, first thing you should ask about history of trauma. Why I'm saying this? 60% of the knee joint problems are just because of the trauma, and 40% because of the other than the trauma. So in the trauma, always you must inquire about the direct injury or it is a twisting injury. So as I said, it is in the direct injury, you can see that there is a bruise here. That means there is a direct hit. There is a direct hit, just like in the dashboard injuries, you can see here, there is a direct hit in the dashboard while sitting in the car, directly hit the upper part of the tibia, that leads to the posterior cruciate ligament injury. So these are all direct injuries. Then what are the indirect injuries? Indirect injuries while playing sports, you can see that there is a knee joint is totally twisted. So once it is going like this, that means the knee joint is going into the valgus. These patients are notorious for injury of the medial collateral ligament. In the gross valgus force, there is a chance of injury into the ACL injury, anterior cruciate ligament injury. There is a combined injuries. So you should evaluate not only individual ligament, there are combined injuries also there. Those also you should evaluate in these patients. These are common with indirect twisting injuries. So indirect injuries, and in indirect injuries also you will see the fractures. So if you see that in indirect injuries, sometimes you may get the avulsion fracture of the ACL. And there is a fractures of the medial condyle and fractures of the lateral condyle, and articulating areas you should exclude. And another important thing, always you should ask for the bleeding disorders in knee joint examination. Any swelling around the knee joint in injury, when the says there is a history of injury, always, all the more if the patient is male, you must inquire about the bleeding disorders. So hemophilia, commonly it is male's disease. The females are carriers. And non-traumatic. So non-traumatic conditions are, again, the rest of all the things are non-traumatic. It is a congenital, infective, inflammatory, and other things. In the non-traumatic conditions, most of the non-traumatic conditions will produce either a localized problem or a diffuse problem around the knee joint. So according to each individual thing, we must inquire about that. So suppose if you take the age of the patient, in a 2 to 10 years of age group, most commonly the problems are either with a congenital or metabolic like rickets and bone tumors, osteogenic sarcoma and osteochondroma. These are the common around the knee joint. And 10 to 15 years age group, we will see that epiphysitis, it is very common. And the bone tumors is also very common at that particular age because it is a growing age. Osteochondroma grows very fast at that particular time. And 20 to 40 years, it is a middle age group. It is trauma because this age group will go for the sports and high activities. These patients are prone for the trauma and the ligamentous injuries and the bone tumors. These are very common in the females. That is, it is a osteoclastoma is an important thing. You should look into that. And 50 years, these are all before 50 years and after 50 years. After 50 years, always you should think of either it is a degenerative problem of that particular joint and it is a malignant lesions also you can see around the knee joint. So degenerative problems is extreme degrees of motion at the knee joint and squatting, and you should ask for the habit of those. Suppose you take the kneeling position, it is most commonly that will lead to early degeneration of that particular joint. And the females are more prone for the degeneration of the knee joint. So those things, we must look into that. So age is an important factor. Sex is also an important factor to decide some particular diseases around the knee joint. So what are the symptoms around the knee joint? How the patient will present to you? So mostly 80% of the patients, they will present to you with pain, and 30% of the people, they present with the swelling and the locking, redness, deformity of the knee joint, limp, and giving way sensation and loss of function. Sometimes it is because of the stiffening. There won't be any function in the knee joint, that is stiffening. It may be because of the infective pathology, or it may be because of the locking of the meniscus, and all the things we should exclude. So each one, we must go into the thorough way to analyze them. Knee pain. First thing, foremost thing is the site. So if a patient can localize the site of the pain, that means your 60 to 70% of your diagnosis is finished. For example, if the patient is complaining of pain or the tibial tuberosity, it is in a young male, a growing age child, it is Ashok-Slaughters. And if the patient is complaining of a pain or the femoral condyle on the medial side, it is a avulsion fracture of the medial collateral ligament. And if the patient says pain around the pus incerna area, probably it is because of the pus incerna bursitis, and pain complaining over the head of the fibula. So after trauma, always you should be very careful that posterolateral corner injuries can present pain at the head of the fibula. So like that, if patient can able to pinpoint the site, that means 70 to 80% of your diagnosis is definitely it is finished. So then onset, whether it is acute onset or chronic onset, all traumatic injuries are acute onset, and all other than traumatic injuries are chronic onset. And acute onset, sometimes it is a locking of the knee joint. Suddenly the knee joint locks either with a loose body or because of the torn meniscus. And progression, how fast it is increasing, and it is at a constant pain is there. So for example, if you take the inflammatory arthropathy, the progression means early morning stiffness is there, and it lasts for 1 hour, and gradually it is relieved, and further activity will increase the pain. Suppose it is a mechanical problem, sir, the initial stiffness is there, but it does not last long for the long time. Then with movement, it eases. But at the end of the day, because the pain will increase. This is classical feature of degenerative problems. And the duration, time span is also important. So as I explained now, it is a early morning pain, it is lasting for more than 1 hour. That indirectly speaks of inflammatory problems. And the character, it is a dull aching pain, is always indicative of arthritic pain. It is a throbbing pain, it is always indicative of septic, inflammatory problem, infection. And the pricking type of pain is also seen in arthritis, as well as sometimes in metabolic conditions like gouty arthritis. And those situations, sometimes you will see that it is a pricking type of pain. And aggravating and relieving factors. In a degenerative pain, if you give the rest, there are mechanical problems. If you give the rest, the pain will be relieved. If you do the work, the pain will increase. It is aggravating. In the inflammatory problems, if you do the work, the pain will increase. And even if you give the rest, the pain won't subside. It stays for some time. So that's how it will be differentiated. And in these relieving factors, diurnal variation is also there. In cold environments, the inflammatory problems will increase the pain, and in hot environments, the inflammatory pain will be relieved. So like that, we have to see that what are the aggravating and relieving factors. Suppose if you do the squatting, complete squatting, if the pain is there, then definitely it is a sign of meniscal injuries. Suppose if the person is going up and down, climbing stairs and getting down stairs, if the patient complaining of pain, it is more in favor of patellofemoral arthritis. And while sitting in the movie theater, suddenly if the patient says, I'm getting, then there is a catch in the knee joint, I could not able to walk, and pain more predominantly in the anterior aspect, then they say that it is a patellofemoral arthritis. It is classically, it is called as movie sign. So aggravating and relieving factors we must assess. And activity related, activity required for daily living. Suppose if a person is walking and suddenly twisted, suddenly the knee gives way and they complaining of severe pain. So this is classically seen in anterior cruciate ligament injuries and patellar dislocation. Suddenly it gives way and the patient complaining of pain. So like that, activity related pains also we must see. So as I told you, location of the knee pain. In anterior, it is a patellofemoral syndrome and Ashok-Slatters, and medial, it is probably because of the meniscus and medial collateral ligament and pus and bursitis. That's why anatomy is very important, knowing of anatomy. And lateral, it is the meniscus and lateral collateral ligament iliotibial band friction syndrome. And the posterior, it is the hamstring injuries, Baker cyst, a tear of posterior horn of the lateral meniscus and medial meniscus also can give you the posterior pain. And sometimes patient may say that there are sounds that are coming from the knee joint. So those are all very important. Those are all diagnostic and very important clues. So crepitus, it is a grating sensation in the knee joint while flexion and extension, if they are doing it, they will get a sound. So if that sound is audible, that means it is audible as well as it is palpable. If it is classically, it is audible means they say that I am able to hear the sound. That means it is coarse crepitus. Coarse crepitus commonly seen in the osteoarthritis and chondromalacia patella. And fine crepitus usually seen in synovial thickening and synovial effusion sometimes. So fine crepitus. And clicks, normally you will see the clicks while doing flexion and extension, they will say clicking sound. Constantly on particular area of the movement, they will get the click. So these are all very important diagnostic things in a meniscal tear and ligamentous tear and osteoarthritis. The commonest cause for the clicking sound is osteoarthritis. Don't think that it is the meniscal tear. And clunk. Clunk means it is a thud. We will call it as a thud. So this thud means this is audible as well as it is palpable. When you do the total knee replacement, sometimes there is a thick fibrotic nodule in the superior pole of the patella. While you are doing the extension, definitely that comes and hits the femoral process and there is a block and suddenly it relieves off. Suddenly it relieves off. That is called clunking sound. It is clunk. Classically, it is seen in the discoid lateral meniscus. With each flexion and extension, patient says there is a thud. And you can able to feel it and you can able to, it is audible outside. So this is called clunk. By history and by seeing that, easily you can able to make out the diagnosis. And snap means it is the rubbing over the bony projection of a particular tendon. It is rubbing over that area. That is classical example is IT band. Iliotibial band rubbing over the lateral femoral condyle. So that leads to a snapping area. And sometimes an exostosis behind the semitendinosus, pus and senna. With each flexion and extension, you will feel that there is a sliding mechanism of these tendons. This is called snap. So this is called snap. So that snap itself will give you the diagnosis. So sounds are very important around the knee joint. Then come to the deformity. So in the deformity, there are three varieties of deformity. There is a sagittal plane deformity and a coronal plane deformity and rotational deformities. These are the three deformities commonly. Sometimes you may have the combination of these deformities. So classically, it is the valgus. Normally, a knee joint is having 5 to 7 degrees of valgus. If it is beyond that, if it is beyond 10 degrees, definitely you will say that it is in valgus. And varus is not at all acceptable. Any varus deformity commonly seen in the degenerative osteoarthritis. It is very commonly seen in the degenerative osteoarthritis. or this is because of the medial femoral condyle or medial growth arrest of the medial femoral condyle or a tibial condyle. And this varus is also commonly seen in the children because of the rickets. And valgus is also commonly seen in the rickets. And it is renal osteodystrophy is the most common cause in this. It is a valgus knees. And sometimes these valgus knees are produced by the osteochondroma tumors that is in the metaphyseal location. Also, they can produce this valgus knees. So, any unilateral pathology is you must look into a local area. This valgus knee sometimes they can be seen in the Cosen's phenomena. That is a metaphyseal fracture in the child. Sometimes that leads to the valgus deformity of the knee joint. So, a child with valgus deformity, you have to look into this, all these things. A varus deformity, usually it is because of the metabolic problems as well as a growth arrest on the medial or lateral femoral condyles. And it is because of the metabolic rickets also that can lead to this varus deformity. And never forget that the varus deformity up to 2 years is a physiological. And from 2 to 4 years, it is the valgus deformity is physiological. From 4 to 8 years, this valgus deformity will reduce and it will come to the normal phase. So never forget about physiological variation of the varus and valgus and a normal valgus position of the limb. And sometimes you will see the wind swipe deformity. This is wind swipe deformity. One side you will see the valgus and other side you will see the varus. This is because of the differential occurrence of this particular problem. Suppose if it is at the age of before 2 years, the patient will get varus. And once the child is shifting into from the 2 to 4 years, if it is in the valgus, then definitely that child will go into the valgus deformity. So the first one is the varus and second one is the valgus. So these are differentially, they are occurring in that particular knee joint that will produce wind swipe deformity. And last one is it is the genu recurvatum. Recurvatum means you must observe this problem from the lateral side. Lateral side. You will see that the femorotibial angle, the anteriorly, posteriorly the apex is formed. Posteriorly apex is formed. Once you see the deformity, this is the most dangerous deformity. Always you must remember this. So the causes for this is in the quadriceps contracted. You have to take the history that any injections given in the quadriceps. And the second one is you have to look at foot, because any patient is having fixed equinus. So they will produce, it is a recurvatum deformity as a secondary deformity. And sometimes if the patient is having a quadriceps deficiency, so once there is a quadriceps deficiency like in poliomyelitis, patient try to stabilize the knee joint with the hand, that is with the hand to knee gait. Those patients will stabilize it, ultimately that land up with a genu recurvatum. So genu recurvatum, once it is there, you must look into the quadriceps function and you have to see the ankle, whether it is equinus is there or not. And you have to see the less power of the hamstrings. Hamstrings also weak. Then quadriceps will overtake. So all these things you must look into this. And next one is the triple deformity. In the triple deformity commonly seen in the tuberculosis, and sometimes you may see in the other causes also. The other causes of the triple deformity, as the mnemonic that is given that, the causes, you can see that triple deformity it is seen in tuberculosis, rheumatoid arthritis, iliotibial band contractures, and polio, and low clotting factors, repetitive bleeding inside the joint that leads to the destruction of the bone, then that leads to a triple deformity. And excessive bleeding in hemophilia also, it is because of repetitive bleeding and hemosiderin that destroys all the ligaments and cartilage in the bones. That leads to the triple deformity. What is triple deformity? It is flexion of the knee joint and a posterior subluxation and external rotation of the leg. These are three constitutes triple deformity. Remember this, it is a flexion of the knee joint and a posterior subluxation and external rotation of the leg. These are the three. If the limb is not only external rotated, if it is going into the valgus, then it is called as quadruple deformity. Quadruple deformity. Nowadays, we are not seeing this because it is now we are treating tuberculosis in a very fast manner, and with advent of good drugs, we are not seeing, rarely we see this now. And what is this? This is the fixed flexion deformity. It is a stiffening. Whenever the patient is presented with stiffening, always you should inquire about that any surgical intervention contemplated on that particular knee joint and arthroscopy or anything, any surgery, and infections also that leads to the stiffening. So the position of ease of the knee joint is flexion. So it will accommodate more space and synovial effusion. Synovial effusion also can lead to the flexion deformity. So that is the position of ease. So any unilateral pathology, always you remember it is abnormal. So bilateral pathologies can be metabolic and can be physiological, but unilateral problem is always pathological. You must inquire about into the cause. And all these deformities are peak at the growth spot. So you should be aware of this. So what is varus deformity? Varus deformity is measured with intercondylar distance. So this is graded up to 5 centimeters. It is normal. From 5 to 7.5 centimeters, it is grade 1. Grade 2 is 7.5 to 10 centimeters. It is grade 3 is more than 10 centimeters. Sometimes both limbs are grossly varus. It will produce a O deformity as well. It appears like a O. So that is because of the varus deformity, as well as there is internal tibial torsion. Both the things combined together, it will produce O deformity. And valgus deformity, it is an intermalleolar distance is widened. Intermalleolar distance is widened, otherwise called as knock knees. Knock knees. It is 8 to 10 centimeters and 10 to 15 centimeters and more than 15 centimeters. These are all called. Grades are given for the valgus deformity as well. But 8, when you consider this 8 is normal, that is at 8 years. Swelling, another important thing. It can be due to traumatic lesions and infections and bleeding disorders, neoplasms and inflammatory diseases. So when the swelling appears, always you should search for whether it is localized swelling or it is a diffuse swelling. So localized swelling always speaks of a localized lesion. So for example, knee joint is surrounding with a lot of bursae, Hessensenna bursae, Morenbacher cyst, and lateral meniscus cyst, medial meniscus cyst, and prepatellar bursa, infrapatellar bursa, and suprapatellar bursa. These are all localized ones. And osteochondroma and giant cell tumor, these are also localized one. One particular area is involved. But in trauma, it is a uniform, diffuse. A bleeding is there, then it is diffuse. If it is a septic lesion, there is a effusion or pus within the joint, it is a diffuse swelling. And inflammatory pathologies like rheumatoid, and it is a diffuse problem. If it is a tuberculosis, it is a diffuse. So diffuse indicates inflammatory and infections and trauma. And the localized lesions, those are infection, that is, it is a either a bone tumor or some other things. So whenever you see the localized lesions, always remember that mnemonic snaps. So where is the site, and any other swellings are there in the body, you must examine, and what is the age of the patient, and whether it is painful or painless, and what is the age of the sex of the patient. That will give you the diagnosis for the bone tumors. And when you see the swellings, always see that whether it is a cystic or it is a arising from the soft tissue, or it is arising from the joint, or it is arising from the bone. From the soft tissue, as I told you, bursa. From the joint, as I told you, it is the meniscal cyst and Morenbacher cyst. And from the bone, it is the neoplasms, or it is because of the infections. All the bursal lesions, soft tissue lesions is cystic in nature. And the synovium, within that synovium is there within the joint. That is also diffuse swelling. You will see that. That diffuse synovial swelling is always doughy feeling, and all the firm. Sometimes you will see the lymph nodes around the joint; those are all firm in nature, and tumors also sometimes it is firm in nature. And hard means sometimes it is the bony lesion. Definitely that appears very hard. So swelling examination, always you must go in these lines, and never forget to take the history. How early, the timing of the swelling. If the patient is having diffuse swelling, so you should ask, after injury, trivial trauma, how early this swelling occurs. If the swelling is occurring within minutes, it is more in favor of hemophilia, especially in the male. Please suspect that within minutes. If the swelling is occurs in the within hours, it is because of the ACL injury or tibial plateau fractures. And if it is occurring in the days, that means indirectly it is saying that it is a slow growing. That means it is because of the synovial pathology, or it is because of the inflammatory pathology, or it is because of the neoplasm. Or low grade infections also will give you a days of the swelling. So the timing is also will give you the clue that what type of lesion it is. So classical examples, it is the suprapatellar bursa and prepatellar bursa, infrapatellar bursa, and pes insignia bursa, and semimembranosis and Mohren-Baker cyst. You can see that there is a meniscal cyst, lateral meniscal cyst, it is grossly extending outwards. So depending on the location, that will give you the clue that where is the pathology. Then another important thing patient says giving way. Giving way means patient says, I am uncomfortable in the knee. So I am unable to do the twisting movements. I am unable to catch the bus. So while I am running, I am feeling that my knee is unstable. So in other words, classically, if you ask that, they will say that my knee is loose. These are the words commonly described by the patient. So loose. When these words are coming from the patient, always suspect it is either it is a quadriceps weakness, which is the most important locking muscle of the knee joint. So if it is unstable, then definitely quadriceps mechanism must be evaluated in these cases. So patellar dislocation sometimes will give you giving way. And meniscal injuries also can give you the giving way feeling. And classically, what we see, anterior cruciate ligament injuries and collateral ligament injuries in the grade 3. That means it is the complete tear of the medial collateral ligament or lateral collateral ligament. We can't say that it is a giving way, but classically it is described as a buckling. In a dislocation of the knee joint and the collateral ligament injuries, they called it as a buckling. Once you are moving it, something is popping out of that particular joint. So that is classically either a medial femoral condyle or lateral femoral condyle is coming out of that particular area. And patella is dislocating out completely, it is out. So that's why it is called as buckling. So giving you a feeling, you must inquire about all these things. And locking. Locking means patient suddenly says that my knee is locked. Sir, I am unable to do the flexion and extension. He cannot move it. It is fixed. So that means it is sudden locking of the knee joint. You must suspect either it is a loose body, or it is because of the meniscus, or it is because of the bucket handle tear, or it is because of the osteochondral fracture fragment that is locked within the both the femur and tibia. So locking is a very important. If it is acute, you have to suspect all these things. And pseudo locking is there. In the pseudo locking, when the patient is having severe patellofemoral arthritis, patient never try to do the movement around the knee joint. Then you cannot do the flexion and extension. While doing flexion and extension, there is a rubbing of the patellofemoral joint that leads to the severe pain. Suddenly the quadriceps will go into the spasm and it locks the knee joint. It never allows him to go into the flexion. This is called as pseudo locking. If you give anesthesia, automatically everything will resolve and you will get normal range of movements. Normal range of movements. So that is called pseudo locking. So once with this history, and in these patients in the pseudo locking, a stiffney also comes under this. Stiffney means patient is unable to do the flexion from 0 to 40 degrees. So 0 to 40 degrees, why it is designed as 0 to 40 degrees as stiffney means, in a normal functions of the knee joint, it needs at least 80 degrees flexion. 80 degrees flexion. So to climb the stairs, it needs 80 degrees flexion. To down the stairs, it needs 65 degrees of flexion. So minimum requirement is 80 to 60 degrees. So if it is a 40 degrees of flexion, patient cannot able to climb the stairs, he cannot squat. So stiffney is defined as if the loss of function beyond 40 degrees. So it is a 0 to 40 degrees, it is limited. So you cannot flex more than 40 degrees. Definitely it is called as stiffening. So when do you suspect stiffening? a pseudex osteodystrophy, and sometimes you will get a quadriceps is contracted completely, and you will see the infections in the knee joint and completely joint is destroyed and fibrotic ankylosis is occurred, and sometimes with the septic infection if the patient will have a septic ankylosis, bony ankylosis. So bony ankylosis, fibrous ankylosis, and quadriceps contracture, severe quadriceps contracture, and all will lead to this. So reflex sympathetic dystrophy also will lead to the stiffening. Stiffening defined as 0 to 40 degrees movement is there. Beyond that, there won't be any movement. When come to the physical examination, once you want to do the physical examination, adequate exposure of the patient is very, very essential. It is from groin to toes is important. Why I told you already, it is from the spine to toes we must examine. When you're examining these patients, you must examine in supine position, lateral position, prone, and standing. But mostly we examine the patient in supine and next standing position, then come to the lateral position, and last in the prone position. So this order must follow. First is in the supine, then in the standing, then in the lateral position, then last in the prone position. Never ever forget that first examine the normal limb first, then only examine the upper limb and compare both the limbs for the reference. So once you are inspecting it, the first thing is the gait. So when the person comes and enters into your chamber, first you have to see the gait. So gait should observe from the front, from the back, and climbing the stairs, and entire walking few steps of gait must be analyzed. So in the gait in the knee joint actually is more important than the hip joint. It is more important than the hip joint. So always you must observe it. There is a varus thrust gait and valgus thrust gait, and there is an antalgic gait and a short leg gait, and the foot progression angle must be observed from the anteroposterior perspective. And from the lateral perspective, you must observe recurvatum thrust and stiff knee gait and flexed knee gait, and a short stride length is also observed from the lateral side. So in the knee joint problems, mostly it is the loss of swing phase because knee is stiff. So swing phase is purely maintained by the knee joint. So once knee problem is there, patient will lose the swing phase and it decreases the stride length, and the foot progression angle will tell you about the rotational deformities. If the foot is inwardly rotated, that means it is an internal rotation deformity. If the foot is outwardly rotated, it will give you the external rotational deformities. So gait will tell you the deformities as well. So for example, you see the hand to knee gait. It is a quadriceps paralysis is there. To stabilize the knee joint, patient is keeping the hand over the knee joint and pushing back, and he is locking the knee joint with the help of the hand. So here it is the quadriceps is weak. That's why he is stabilizing with the hand to knee gait. This is classically seen in polio. And this is the short limb gait. Short limb gait means one side limb is shortened. So automatically the body sways to the normal side. So once it is swaying to the normal side, sound side, that is short limb gait. And here you can see that. So patient is having a foot drop, then it produces high stepping gait. It is classically seen in the common peroneal palsy, which is very common, which is around the knee joint. So you must examine this. Then another important thing is the antalgic gait. It is a painful. You can see that the less stand space is there, and patient is having short stride length. Short stride length. Then stiff knee gait, once the knee is stiff, there is no swing phase. So automatically the patient will do the circumduction at the hip joint. So circumduction gait is commonly seen. And last one is the varus thrust gait. Observe this varus thrust gait. So the knee is going into the varus when the patient is having mid stance of the particular limb. You can see that. In the mid stance phase of the foot, the patient knee is buckling. It is varus, it is going into the varus. This is called varus thrust gait. This is commonly seen in the medial tibial defects like in osteoarthritis, and sometimes you will see this varus thrust gate in the posterolateral corner injuries, which is very dangerous. So this varus thrust gate is very important. Then inspection from the side. So inspection from the side, it is a spine you have to examine. Why you have to examine the spine means any hip problems will give the lumbar lordosis, and hip problem pain may complaining of pain in the knee joint. So that's why you have to examine. Any ankle problem equinus that will leads to the recurvatum. So that is observed better from the side. And the pelvis also you must see, when you stiff gait, the pelvis will rotate while walking it. So you have to examine the pelvis. And the hip will go into the flexion, but it never go into the flexion. Always they will do the circumduction gait in these patients. And hip is involved, then patient will have exaggerated lumbar lordosis and the hip flexion will go there. Then automatically the patient won't get the knee complete extension. He never clear the ground. Then knee flexion deformity and recurvatum. So this recurvatum because of either quadriceps contracture or because of the equinus of the foot. So ankle and foot examination is must in these cases. And the surgical scars you must observe from the lateral side. Most of the times it is high tibial osteotomy. The scar is on the lateral side at these areas. So inspection from the back is the last one. So it is in the spine also you must examine. Why? Because any swellings in the popliteal fossa are in the medial aspect of the joint, which is not hot. So cold abscess is commonly present in along the neurovascular sheath. In the lumbar tuberculosis, sometimes all the abscess can travel across that and across the hip, and it can present at the knee joint. So that's why spine must be examined. And pelvis, any hip joint problems also can present with this. And popliteal creases you must examine. Crease is normal or not. Any elevation is there. That elevation is already the indirect clue to say that there is a hip joint problem is there. And calf muscles you must examine. Any atrophy of the calf muscles and any atrophy of the hamstring muscles you must examine. And at the same time you must see the hind foot alignment. So whether the hind foot is varus or in valgus. In a valgus knee, hind foot will go into the valgus and the pronation of the foot is there. And you will see the too many toes sign on the lateral side. And if the hind foot is in varus, in a varus knees, hind foot will go into the varus and you will see the foot is in supinated position. So that's why foot examination indirectly will give you. It is called as genu valgum complex or it is called as genu varum complex. So inspection and sitting is also important. So ask the patient to sit on a table and flex the knee joint up to 90 degrees. When you flex the knee joint in 90 degrees, patella directly articulate in the anterior aspect of the femur. So while you are examining in sitting position, knee flexion, you will observe the patella alta and patella baja. So you will observe the patella, whether it is high riding patella or it is a low riding patella. And movements of the knee joint also you can observe in this particular thing. If the patella is high riding, then it is called as patella alta. If the patella is coming nearer to the tibial tuberosity, it is called as patella baja. Then come to the palpation. In the palpation, it should go in a systematic manner starting from either it is a clockwise direction or in an anti-clockwise direction, you must examine the knee joint. So in this first, you have to feel the temperature, then you have to feel the tenderness, and if there is any effusion or any synovial hypertrophy. So the best site to see the synovial hypertrophy, it is in the supromedial aspect of the knee joint, where the vastus medialis is there. That is the first muscle that is going to be atrophied in any pathology of the knee joint. So that's why there you can easily palpate the synovium. So when you are palpating it, it rolls under your knee. So, and the feeling of the synovium, sometimes it is doughy. So synovial thickening, any pigmented villonodular synovitis or synovial thickening, chronic non-specific synovitis, or it is because of the tuberculous synovitis, or it is because of rheumatoid arthritis. And in all these conditions, the synovial thickening we can appreciate in this area. So when you are starting palpating it, you palpate in a clockwise direction. You come it like this. So first thing, you have to feel the quadriceps. How is the tone and the bulk of the quadriceps? Then you come to the quadriceps tendon. Is the tendon is directly attached to the superior pole of the patella? Any gaps are there? That will tell you there is a rupture of the quadriceps tendon. And then come to the medial side. You have to feel the medial side. And joint line, you have to feel it. Once you feel the joint line, then you feel the hamstrings. Then you will feel the medial collateral ligament in that medial side. Then you come to the tibial tuberosity. Then you feel the patellar tendon, the inferior part of the patellar tendon, where it is a swelling in the tibial tuberosity or swelling in the inferior pole of the patella. So there also we have to see any swellings. And after that, you shifted to the lateral side, you feel the Gerdy's tubercle. Gerdy's tubercle. Then you feel the joint line. Joint line is best appreciated with flexion. Never see joint line in extension. So joint line is best appreciated with flexion. Then you have to examine the lateral collateral ligament. Then you examine the iliotibial band. Then you examine the biceps femoris. Then you see the superior pole of the patella. Superior pole of the patella on the lateral side and in medial side. Why you have to examine these two areas means it is retinaculum, lateral retinaculum and medial retinaculum are attached to these areas. So if you observe this, the lateral side halonus is higher than the medial side because vastus medialis attaches very lower areas. So if these halonus is obliterated, that indirectly will give you that it is there is a fluid or synovial thickening is there or something abnormal within the knee joint. So palpation inflection. So anteriorly, as I said, patella, ligamentum patellae, head of the fibula, and you have to feel the synovium. And on the medial side, it is a medial joint line in 90 degrees of flexion. You palpate the tibial tuberosity and shift it to the medially. Then you go upwards along the medial tibial condyle. Suddenly your finger dips in the inside. So at that point is called as medial joint line. And you have to feel the medial epicondyle, medial collateral ligament on the femoral attachment. Sometimes you will see the swelling at the medial epicondyle area. That means it is an avulsion injury from the medial epicondyle in a child, that is pellagrina steady disease that we'll see at this area. If you see swelling at the adductor tubercle area. And pus and sirna can be examined in the flexed position very easily. And spasm of hamstrings also, it is very classically seen in this. From the lateral side, you should examine lateral collateral ligament. Lateral collateral ligament best examined in figure of 4 position. You keep the figure of 4 position and identify the head of the fibula and you follow the head of the fibula. There is a taut structure that is going superiorly and it is inserted into the femoral condyle. So that is lateral collateral ligament. Normally, in a normal flexed position or in extension, it is very difficult to feel the lateral collateral ligament. Lateral collateral ligament best appreciated in a figure of 4 position. Then you can appreciate the biceps tendon. At the same time, common peroneal nerve also you can able to feel the just below the biceps tendon. And common peroneal nerve is also palpable around the neck of the fibula. So you must feel it. And iliotibial band also you can feel in the lateral aspect, superolateral aspect of the knee joint. So lastly, exam from the posterior aspect. Ask the patient to lie down in prone position. When the patient is lie down in prone position, in extension of the knee joint, it is very difficult to feel anything in the popliteal fossa. So to examine the popliteal fossa, and you must need to flex the knee joint to relax the deep fascia and to relax the capsule. And so flexion of the knee joint is very, very important. In this, you can examine the popliteal cyst. And semimembranosus is located eccentrically between the semimembranous and gastrocnemius, and it is above the joint line. This is a very important thing we must remember. And all the Bacchus cysts mostly they are in the center, and at the level of the joint or just below the joint, And this is best visualized whether it is swelling is because of the fluid, or it is because of the pulse, or it is because of the synovium, or it is because of the blood. That can be better appreciated with the transillumination. But never forget that in the central location of the any swelling in the popliteal fossa, always remember The popliteal aneurysms are second commonest aneurysmal site. So always you should feel it. Then you will feel the pulsations, and sometimes you can hear the bruit in this area. Sometimes there are transmitted pulsations can be appreciated through that. That is identified with the hold the swelling and lift it up. If the transmitted pulsations are decreased, that means it is a transmitted pulsations. If the pulsations are as it is, that means the swelling is classically from the popliteal artery. So never forget to examine for the lymph nodes in the popliteal fossa. Popliteal fossa lymph node is commonly from the posterolateral aspect of the foot injuries, or because of the knee joint problems also can drain into the popliteal fossa lymph nodes. And abscess that is seen in the popliteal fossa is because of the lymph nodes. Most of the times it is tuberculous infection or because of the foot lesions. And never forget to examine the neuromass around the neuromass. Definitely classically will give you, once you feel it, it will give an electric shock like sensation. Once you see it, you never forget in your lifetime. And there is a lipoma also, one of the possibility in the popliteal fossa, you should examine for that. And test for intra-articular fluid. So once there is a test, fluid is there. What is the normal amount of fluid in the knee joint? It is 7 ml. So if it is beyond that, there is a huge effusion. The knee joint can accommodate up to 100 ml of the fluid. So according to that, it is a minimal effusion, moderate effusion, and tense effusion. They divided it. Minimal effusion means it is 20 to 40 ml. Less than 40 ml, you will call it as minimal effusions. Less than 20 ml, it is called minimal effusions. And 20 to 60 ml, it will call it as moderate effusions. Beyond 60 ml, it is called as tense effusions. Why it is given like that means a patellar tap is classically elicited in the moderate effusions only. It cannot be elicited in minimal effusions and tense effusions. So patellar tap, how do you do the patellar tap? You empty the suprapatellar fossa with your palm. Once you empty it, that means the whole fluid comes beneath the patella. Then with the two fingers, you just press the patella downwards. This will have a tap over it is a ballotment. You will see the ballotment of the patella and it's the femoral condyle. The patellar tap is pathognomonic sign of fluid within the joint. And in synovial thickening, you never get patellar tap positive. This is a very important point we must remember. Patellar tap in synovial thickening, you never get patellar tap positive. Then come to this is moderate effusions. In the tense effusions, you never get patellar tap positive because the fluid displaces the patella out of the joint. And in a patellofemoral arthritis where the patella is already articulated in 30 degrees of flexion deformity also, even though fluid is there, you never get the patellar tap positive. And the patella is adhered to the femoral condyle, also you never get the patellar tap positive, even though the fluid is there. This fluid will give you classically a horseshoe-shaped swelling. Horseshoe-shaped swelling. Then if it is a minimal fluid, how do you identify that? Minimal fluid, you will see the either stroke test or bulge test or wave test. It is you displace the entire fluid to one side and you stroke to that opposite side. Then automatically that fluid will come to the same side. Once you're emptying it, entire fluid comes downwards, and if you stroke one side, then that fluid will shift to the opposite side. You will see a wave that is going onto the opposite side. So that is called stroke test. This is the classically seen in minimal effusions. And juxtapatellar halo test. This means even though if it is a small fluid is there, so ask the patient to stand up, and there are parapatellar tendon halos are there. If you observe in the infrapatellar area, so there are halos. You keep your thumb and index finger by the side of the patellar tendon and you ask the patient to stand up. And you suddenly relieve that both the fingers. Then gradually that space is filled with the fluid. So the minimal amount of fluid can be tested with this juxtapatellar halo test. And this one is the transillumination. Transillumination will give you if there is a clear fluid is there. Once you do the transillumination test, definitely it is positive. If there is a blood or pus or any other thing is there, then definitely transillumination test is negative. So synovial effusion A sympathetic effusions are best visualized with this transillumination, and hemarthrosis also can able to differentiate with the transillumination test. Then come to the movements. So what are the normal movements of the knee joint? It is from the 0 to 140 degrees. It is 0 to 140 degrees. Some thin individuals, it may go up to the 160 degrees. Why I'm saying this? The calf will touch the thigh. So that is the normal range of movement. So if in a obese individual, obese females, most of the times the calf will touch the thigh, but here the foot never touches the thigh. If the foot touches the thigh, that means it is 160 degrees. If the foot is not touching, if the calf is touching the thigh, the full range of movement is there. Yeah, we should remember that is the normal range of movements. And one important thing we must remember that it is an extensor lag when we are doing the describing the movements. So extensor lag means you ask the patient to sit on the table and ask him to extend it. The patient can able to extend up to the short of 20 degrees. But if you passively extend it, definitely you will get complete 0 degrees of extension. Up to 0, you will go it. So that means it is an extensor lag. This extensor lag is a very important finding. If the patient is having quadriceps weakness, they will get extensor lag. And if the patient is having patellectomy, also those patients will have extensor lag. So these two things are very important. If it is a fixed deformity, the extension is not possible as usual routine. Any fixed, once you say fixed means opposite movement is not there. Those things are. Then active movements and passive movements also you must examine. Active movements indicates integrity of the neuromuscular continuity. So if the patient can able to do active movements means neuromuscular continuity is there. If the patient is unable to do, the passive block is there means there is a mechanical block inside the joint. Either it can be extra-articular or it can be intra-articular. So why you have to see this? This is a very important. Extra-articular adhesions and intra-articular adhesions are best visualized by the movement of the patella. If you see the movement of the patella, if the patella is able to lift off, that means it is extra-articular contracture. If you are unable to lift the patella from the knee joint in a complete extension, that means it is intra-articular pathology that is restricting the movements. So this is a very important clinical test that will tell you the restriction of the movement. While you are doing movements, always feel for the crepitus and sounds. That will give you the clue. Then measurements. These measurements are, you have to girth of the thigh because that will tell you about the wasting of the thigh muscles. That is from the 15 centimeters above the superior pole of the patella. You have to do that. And from the tibial tuberosity, you will go for the 10 centimeters downwards and you can see the girth of the calf. So these two will give you the atrophy of the muscles and wasting of the muscles that will tell you. And active extensor lag test. Once you're extending it, you measure how much extensor lag is there. If it is more extensor lag means quadriceps function is less. And these patients are known for the buckling and there is a frequent falls. And you have to measure the Q angle. So here for the practical, for the demonstration purpose, I kept in the standing position, the Q angle measurement, but Q angle can be measured in the supine position, standing position, and in sitting position. In the sitting position, Q angle, complete flexion of the 90 degrees flexion of the knee, both the lines of the patellar tendon and the line from the anterosuperior leg spine to center of the patella, both are in a straight line. But in supine position, if you measure the Q angle, that is the best position. You have to measure the Q angle in supine position. Even in standing position also, the Q angle can change because of the valgus, a medial collateral ligament laxity is there, then automatically a valgus deformity, then definitely they will have increased Q angle. Increased Q angle. So standing, normally this Q angle is in the males 13 to 16 and in the females is more up to, it can go up to the 17 to 18 degrees. Anything beyond 20 degrees of the Q angle, it is definitely abnormal. This Q angle measurement is very important. It will tell you about the quadriceps function. Then last one is a tibiofemoral angle. You measure it from the anterosuperior leg spines to the center of the patella, from the center of the patella to the center of the ankle. So it will form an angle. So this indirectly will tell you whether the joint is in valgus or varus. This is an objective measurement of the varus and valgus measurements. This is an important test. So then come to the patellofemoral joint. The patellofemoral joint is a very important structure. It is surrounded by the medial retinaculum and lateral retinaculum. There are different tests you must examine for. You must see the size of the patella, shape of the patella, and the position of the patella, and vastus medialis obliquus disposition. So size means if it is a small patella, is mostly commonly seen in the nail patella syndromes. And the shape of the patella, it is a bipartite patella. Sometimes you will see in these patients. And the position of the patella, it is a medially squinted or laterally squinted. So if it is a medially, it is looking, that is seen in the anteversion. If it is laterally looking, it is seen in the genu valgum. The patella appears to be laterally looking. And C for the osteophytes. Superior pole of the patella is known for the osteophytes. And the tenderness of the medial facet and lateral facets under surface, if you examine it, then definitely that will tell you any patellofemoral arthritis or chondromalacia patella. And Clark test. So to identify the patellofemoral arthritis, a passive patellar grinding test and active patellar grinding test. In a passive means you apply pressure over the patella and you try to rub it over that femoral condyles, or you press it and ask the patient to contract the quadriceps. Then if the patient says pain under the surface of the patella, definitely it is a patellofemoral arthritis. And active means you ask the patient to flex the knee joint and you apply pressure over the patella and ask the patient to do the extension of the knee joint. Then definitely if the patellofemoral arthritis is there, definitely it will produce pain. Then patellofemoral functional test. Simply remember that mnemonic is called APJ President's question. APJ Abdul Kalam President's question. APJ President's question. A means apprehension test. It is nothing but Fairbanks. And patellar glide test, it is nothing but Say's test. And J tracking test, J sign. And patellar tilt test and Q angle. So all of these things we must inquire about that. So apprehension test is ask the patient to lie down supine and keep the patella and you push the patella towards the lateral side in extension, then slowly make the knee joint flexion by the side of the table. So by reaching it 20 to 30 degrees of flexion, immediately patient will complaining of apprehension. Immediately the quadriceps will go into the contraction and patient never allow it to do it. This apprehension test is a pathognomonic sign. There is a dislocation of the patella. Acute dislocation of the patella. Then it is a patellar glide test. It is a patellar glide test will tell you what about the retinaculum. How much movement of the patella. If you divide the patella into 4 quadrants, so in a normal individual, it will shift up to 2. It never go beyond 2 quadrants. If it is going beyond 2 quadrants means the opposite side, that is the lateral retinaculum is weak and medial retinaculum either it can be contracted. And you have to do both the directions. In the lateral side, you have to shift it, and the medial side, you have to shift it. So if it is less than 1 quadrant, if it is shifting means that side is contracted, that opposite side. If it is shifting towards the lateral side, if it is less than 1 quadrant, it is shifting means medial structures are contracted. This will give you the contraction stability of the medial retinaculum and lateral retinaculum. Patellar glide test is very important if case comes with the patellar dislocation. And this is an active test, J test. From the flexion to extension, if you ask the patient to do the extension, normally this patella goes straight. But here, patella shifted towards the lateral side while doing extension. So this is called a J sign, active test, active extension. And patellar tilt test, you lift the patella from the lateral side. If you can able to lift it, the patella for only 10 degrees, or you can lift the patella only 5 to 1 centimeter. If you are lifting patella more than 1 centimeter, that means that lateral retinaculums are weak. If you are on the opposite side, if you are able to do that, that medial retinaculum is weak. So patellar stability tests or instability tests are mnemonic is APJ President's question. A means apprehension, P means patellar glide test, J means tracking test, and patellar tilt test, and last one is the Q angle is very important. So what is Q angle? I already described that Q angle is drawing from the anterosupial exponent center of the patella from the center to the tibial tuberosity. So what are the conditions will increase the Q angle that leads to the patellar instability? In the Q angle word itself, we will give you the what are the causes. So AN means anteversion of the femoral neck, that will increase the Q angle, and G means it is the genu valgum, and L means lateralization of the tibial tubercle, and E means external tibial torsion. So simply Q angle, quadriceps angle, Q means it is the quadriceps angle that is increased in all these conditions. You must check for femoral anteversion and see the genu valgum and external tibial torsion and the lateralization of the tibial tubercle you must examine. So any traumatic lesions, any painful lesions, it is very difficult to examine without anesthesia. So any painful lesions, it is better to examine under anesthesia. That will give you absolute information. Absolute information. So with this, now we are going to discuss about the special tests. Special tests. Those are all special tests for about a medial collateral ligament and lateral collateral ligament and anterior cruciate ligament and posterior cruciate ligament and combined instabilities. Also, we can able to discuss in these things. So all these ligaments in the knee joint, what are the most important ligaments? The most important ligaments of the knee joint are medial collateral ligament and lateral collateral ligament. The next important ligament is posterior cruciate ligament. Next important ligament is ACL, anterior cruciate ligament. You always, this is the fundamental. You please remember this. The collateral ligaments are first, then PCL is the next, then last is the ACL. So once you want to do that collateral ligament, first I want to test the collateral ligaments. Why you have to test the collateral ligaments first, I will explain later on. So first you have to test the collateral ligaments. So medial collateral ligament is an important restraint for the valgus thrust. So how do you test the medial collateral ligament? Because the posteromedial complex is completely, it is a posterior oblique ligament, and semitendinosus, semimembranosus, and gracilis and all medial complex structures are supporting the medial collateral ligament. But you have to avoid those supporting structures, then you have to specifically test the medial collateral ligament. Those avoiding is by the 15 to 30 degrees of flexion. If you do it, all the posterior structures will be relaxed and purely you are testing the only medial collateral ligament. That is the reason why you have to test the medial collateral ligament in 15 to 30 degrees of flexion. 30 degrees of flexion, then you apply the valgus force. This is the classical testing of the medial collateral ligament. You keep your hand over the knee joint and another hand over the ankle joint, then you apply the force. So opposite, this indicates the direction of the force. If the medial collateral ligament injury is there, there is an opening of the medial joint space. If the medial joint space is opening means, then definitely that says it is a medial collateral ligament injury is there. If patient says pain means it is a partial injury of the medial collateral ligament. If the patient says no pain but medial side it is opening means it is a complete rupture of the medial collateral ligament. And the same thing, it is the varus force for the testing the lateral collateral ligament in 15 to 30 degrees of flexion. If the same test if you are doing in the complete extension, that means you are testing both the collateral ligament as well as either it is a posteromedial complex or it is the posterolateral complex. If you apply the varus thrust in extension means you are testing the lateral collateral ligament as well as posterolateral complex, and as well as if you are doing the valgus thrust, you are testing the in extension, complete extension, you are testing the posteromedial complex as well as you are testing the medial collateral ligament. So this test should be done in 30 degrees flexion and in complete extension. That will give you the clue. So if it is opening in complete extension, that says, if it is opening in complete extension, there is an injury to the medial collateral ligament and there is injury to the posterior capsule and posterior complex, and sometimes cruciate ligaments also injured in these injuries. So remember this, cruciates, posteromedial complex, and medial collateral ligament injuries also is diagnosed with the opening of the knee joint in complete extension. So now let us see for the anterior cruciate ligament, anterior stabilizing structures. So anterior stabilizing structure is predominantly the anterior translation of the tibia is stabilized by the anterior cruciate ligament. Anterior cruciate ligament. This anterior cruciate ligament is best tested. What is the function of the anterior cruciate ligament? It prevents the anterior translation of the tibia over the femur. So this word is very important. And what are the structures that prevents the anterior translation? It is hamstrings, those prevents the anterior translation. So both are supporting structures. Both are supporting structures. So once you want to test the anterior cruciate ligament, in an anterior cruciate ligament injury, first you have to test the posterior cruciate ligament. Without testing the posterior cruciate ligament, never test the anterior cruciate ligament. Why? What is the reason for that? So first you look for the posterior sag sign. So in the posterior sag sign, if you keep the limb in the 90-90 position, then tibial tuberosity of the injured side will drop down. So this is called drop back sign, drop back. The proximal part of the tibia is dropped posteriorly. So once there is a drop posteriorly, that means it classically indicative of posterior cruciate ligament injury. But unfortunately, once you try to pull the tibia anteriorly translated, because the anterior cruciate ligament is already intact, it never allows it to go further forwards. So it is a misconceptionally, you will say that if because of the posterior cruciate ligament, already tibia is dropped back, because you are pulling anteriorly, it translates anteriorly. So you will think that it is a anterior cruciate ligament injury, but it is not true. So once there is a posterior sag is there, you are testing the posterior cruciate ligament. And if the posterior sag is not there, then you are testing the anterior cruciate ligament injury. So how do you test this anterior cruciate ligament injury? By the Latchman test, it is 15 to 20 degrees of flexion of the knee joint. Flexion of the knee joint. And you can observe here in the video, you can see that hold the femoral condyles with the one and tibial condyles at the level of the tibial tuberosity. Then you fix the femur. And translate it. So you can see that the tibia is translating anteriorly, and it is going into the normal position. And this is the pathognomonic sign of the anterior cruciate ligament injury. Why I will explain after explaining the anterior droid test. In the anterior droid test is also another test. Is important, you must do it. Here you have to keep the hip in a 45 degrees flexion and knee joint in the 90 degrees flexion. Then you have to sit on the foot to stabilize the ankle. Then you hold both the hands, you keep on the tibial tuberosity level and hold the tibial condyles. And both the index fingers should touch the hamstrings. This is the most important point you must remember. Both the index fingers on both the sides, it should touch the hamstrings to identify whether the hamstrings are in spasm or not. If the hamstrings are in spasm, those hamstrings will pull the tibia backwards. So it never allows it to translate anteriorly. So to identify the hamstring spasms, you must keep it. Then you pull the tibia anteriorly towards a direction of the force. So once it is moving anteriorly, that means the anterior droid test is positive. So how much it should travel? So from the 5 millimeters to up to 1 centimeter, it should go. So before doing all these ligamentous injuries, please verify whether the patient is having any ligamentous laxity by Beaton's criteria. First you examine ligamentous laxity by the Beaton's criteria, then only you do all these tests. So if the patient is having already ligamentous laxity, these ligaments may be abnormal and you will get a false positive. So always you should make a habit of examining the opposite limb to compare this. If both the translation and both the limbs is same, that indicates patient might have a ligamentous laxity. So the traumatic injury area side, you should have more. If the ligamentous laxity more than 1 centimeter, anterior translation of the tibia more than 1 centimeter, always suspect it is both ACL and PCL is injured. With ACL injury, the anterior translation is only up to 1 centimeter. More than that, you should suspect both ACL and PCL injuries. And Slocum test. This will tell you about the anteromedial instability and the anterolateral instability. This Slocum test is, you can see this here. I stabilize the foot in the neutral position. You do the anterior drawer. Then you have to do the foot in the 30 degrees internal rotation and 15 degrees sectional rotation. So you see that first you examine in neutral. No, 30 degrees of internal rotation. 30 degrees of internal rotation and 15 degrees of lateral rotation. So this is about Slocum's test. And pivot shift test is the most important test, whether you test it anterolateral, and the Slocum test is not much important, but if you are doing good in exam, definitely they will ask you. But Latchman test and anterior drawer test is very, very important. You must test it, and pivot shift test. These three tests must be done for the ACL. So why you have to do Latchman is a pathognomonic than the anterior drawer? In 90 degrees of flexion, the menisci will act like a doorstop mechanism. Sometimes in the meniscal injuries, the knee is already fixed. So sometimes you may not get the complete anterior translation, or the doorstop mechanism of the meniscus will stop the anterior translation of the tibia sometimes. So in the extension, 30 degrees of flexion, the doorstop effect of the meniscus will not be there. Clearly you will get the anterior translation of the tibia. So Latchman is the pathognomonic sign. And pivot shift test. Pivot shift test means it is testing the anterolateral structures as well as anterocruciate ligament injuries. So once you, how to do this test? So this test is always from extension to flexion. And what are the prerequisites to get the positive pivot shift is definite ACL tear must be there. And intact MCL is very, very important. So that's why you should test the collateral ligaments first to have a good understanding of these other tests. So if the collateral ligament tested first, then definitely you can say to the examiner, yeah, if the MCL is injured, how can you do the pivot shift test? You cannot do. So to test the collateral ligaments first is very, very important. So intact MCL is must, and intact iliotibial band is also must. So what is the reason for this? So in this test, you do the complete extension of the knee joint, then hold the foot one hand and do the internal rotation, then another hand over the proximal part of the tibia. Then from complete extension to you do the flexion, and you have to apply the valgus force, and you lift the tibia upwards. So once you internally rotated, this tibia rotates and translates anteriorly in extension. So once you are bringing back to the 30 degrees of flexion, iliotibial band, instead of acting as an extensor of the knee joint, it will act like a flexor of the knee joint. It will reduce the tibia to the normal position. So you can observe this. You can see classically there is a reduction in 30 degrees of flexion. Reduced. Here tibia is anteriorly translated and reduced in the 30 degrees of flexion. So what are the posterior laxity? So posterior cruciate ligament is the most important thing that will restrain the posterior translation of the tibia. So that is observed by the posterior sag sign and drop back phenomena. So that is the best is Godfrey test. If you keep the knee joint in the 90 degrees flexion, then you will see the posterior sag of the proximal part of the tibia. And the posterior dry test is done in the 45 degrees of the hip flexion and 90 degrees of the knee, and sit on that as like a anterocruciate ligament. But here the direction of force is going towards the posterior side. So if it is going posterior, there you have to identify whether the end point, what type of end point you are seeing it, whether it is a hard end point or it is a mushy end point or a soft end point. If you get soft end point, definitely it will say that it is a PCL rupture. If you get a hard end point, there is no PCL rupture. So here you can see that if the patient is getting PCL injury, then it is coming anterior. So the displacement is more than 1 centimeter. So here the both cruciates are injured. The displacement from the posterior to anterior, if it is more than 1 centimeter, that indicative of both ACL and PCL injuries. You can see how much translation you are getting it. Both PCL and ACL injury, you will get this much of translation. And another test is quadriceps active test. So you stabilize the foot, 45 degrees of hip flexion and 90 degrees of knee joint, and you stabilize the foot, then ask the patient to do the quadriceps contraction. So then, because quadriceps is attached to the tibial tuberosity, once it is contracting, already posterior sag tibia is lifted up. This is active quadriceps test. It is suggestive of posterior cruciate ligament injury. And last one is posterolateral laxity. It is a posterolateral corner injuries. Corner injuries are best examined with the external rotation recurvatum test and the dial test. In external rotation recurvatum test, we know that either it is a posterolateral corner or PCL injury combined together. So you lift the varus thrust injuries are very commonly to produce a posterolateral injuries. So varus thrust injuries. So that's why you lift the great toes, holding it and you lift it. Once you are lifting it, you are creating hyperextension at the knee joint. In an injured knee, once PCL is damaged or posterolateral corner is injured, the knee will go into the hyperextension. Once it is going into the hyperextension, definitely there is a possibility of PCL injury or posterolateral corner injury is there. Here we are doing the external rotation. So once you are doing the external rotation, you are stressing the posterolateral corner. So definitely a patient will develop varus problem, varus of the limb, as well as hyperextension and the gross external rotation of the foot. If you see that in external rotation recurvatum test, that indirectly says PCL and posterolateral corner injuries. And dial test is another important test that can be done in supine and prone position. Here, ask the patient to lie down in prone position, and in 30 degrees of flexion of the knee joint, you rotate both the feet externally, external rotation of both the feet. Once you are rotating it, in 30 degrees of flexion, if the injured limb is more externally rotated, that means it is a posterolateral corner is injured. And in 90 degrees of flexion of the knee joint, if the foot is more externally rotated, then it is indicative of PCL injury, posterior cruciate ligament injury. If both the areas it is grossly rotated, that means it is a combined injury, posterolateral corner injury and posterolateral. So the variation must be more than 10 degrees for the normal and injured thing. If it is more than 10 degrees only, it is significant. Otherwise, it is not significant. Test for meniscus. So most commonly, it is the McMurray test is commonly what we do. In the McMurray test, for the medial meniscus, keep the knee joint in complete flexion and keep the foot in externally rotated and apply valgus force and extend it. So while you are doing this, if the patient complaining of click or pain on the anterior medial aspect of the joint line, then definitely the test is positive. So varus test and internal rotate the foot, and from the flexion to extension, if you do it, if the pain complaining on the lateral side, then definitely it is suggestive of lateral meniscal injury. And the pain and click, in which angle you are getting it, is that indirectly gives you the clue whether it is a posterior horn is injured or the body is injured. Anterior horn rarely you can able to appreciate with the Mcl test. So if the initial extension, if you get the pain or click, that means posterior horn is injured. Or in the middle of the extension, if you get the pain or click, it is the body, middle part of the meniscus is injured. Anterior part rarely you will get with a Mcl test positive. And most important is the joint line. For the meniscal injuries, most important thing is the joint line. You feel the joint line just posterior to the collateral ligament and posterior to the medial collateral ligament and lateral collateral ligament. So if the joint line tenderness is the most important of all the tests to say that whether the meniscal injury is there or not. And Applies grinding test is both the collaterals as well as you can test the meniscus, but this is the crude test. So nobody is doing right now this test. Next test is the Tasali test. In this Tasali test, ask the patient to stand on the normal limb, then rotate. So that means axial loading the meniscus and you are rotating it, both medial meniscus and lateral meniscus. Then you do 20 degrees of flexion, then you rotate. So in the 20 degrees of flexion, if the patient says pain on the medial side, then definitely it is a medial meniscus problem. On the lateral side, definitely it is a lateral meniscal injuries. And these tests can be positive even with osteochondral injuries or any arthritis sometimes. Those are not that much specific, but patient says there is a classical, a pinpointed location of pain. Definitely that is more suggestive of this. Then what is the importance of all these tests? So joint line tenderness is 70 to 80% specific, and a Mcl test sensitivity is very less. Once it is there, it is more specific. So Applies, the Tasali test is also 80 to 70%, it is more specific. But of all this, most important is the joint line tenderness. Along with the joint line tenderness, any of the test is positive, it is 95% the clinical test is positive for the meniscal injuries. So you have to do all these tests. So last one is Osteochondritis Desiccants. It is the most commonly medial femoral condyle lateral aspect is affected. So this is the Wilson test. Keep the 90 degrees flexion and internally rotate. Once you do the internally rotated, that means the medial tibial spine is coming and touching the lateral aspect of the medial femoral condyle. So you do the flexion and extension. So normally at the 70 degrees of flexion, usually patient says pain. So then immediately you do the external rotation, then patient pain will disappear. Why? The medial tibial spine is not touching the medial femoral condyle in external rotation. So the pain disappears. Then the test is positive. But rather than this, if the patient is having severe pain, local tenderness on the medial femoral condyle on the medial lateral side, definitely that is the pathognomonic sign of the osteochondritis desiccants. That is the clinical test, definitely that will give you. And osteochondritis desiccants is very common in the male child. It is not that much common in female, but chondromalacia patella is very common in females. So another test for the genu varum and genu valgum, how to differentiate these. These are very common tests. So you do the flexion test. In the genu valgum, you do the flexion of the knee joint. If the total deformity disappears, the problem is lying within the femoral condyles. If the deformity is not disappeared as it is, the problem is lying within the tibial condyles. If the problem is partially reduced, that means the problem is in both the condyles. This is the classical description for the flexion test. This is very useful to identify to localize the lesion. And last one is the cover-up test. It is a screening test for the tibia vara, Blount's disease. So you see that whether the tibia is in varus position or not. You cover the distal part of the leg, then you observe it. A line is drawing from the anterosubular spine to the center. Then you see the ligamentum patellae from the center to the tibial tuberosity. In cover-up test, if the tibia appears to be neutral or straight or in varus, definitely it is abnormal. You have to observe and follow the patient. If the tibia is in outwardly rotated, That means there is a valgus, it is seen, then these patients are physiological varus of the tibia. So you need not worry about these patients. Cover-up test is a very useful test to identify Blount's disease. So neurological examination, you have to do common peroneal nerve and superficial peroneal nerve and deep peroneal nerve sensations, and the motor examination of the quadriceps, hamstrings, and dorsiflexors of the foot are very, very important, and peroneal nerve injury is very common in the knee joint problems. And Hansen's is also very common around the knee joint. There is a common peroneal nerve commonly affected with this. And distal vascular examination is also important because knee joint dislocations will produce a vascular deficit as well as neurological injuries. So to identify all the pulses, and ankle brachial index measurement is very, very important to identify any minute deficit of the vascular supply to the lower limb in a knee joint injuries. And last, always examine opposite side to compare the diseased side. And for the management aspect also, opposite knee should be normal. And ipsilateral hip, never forget, most of the times it will deceive you in a normal knee joint with pain. Most of the time, these patients are having problem in the either hip or in the spine. You must examine. And always when the patient is having deformities, it is the rule of thumb, joint above and joint below must be examined. Ipsilateral foot and ankle must be examined. And spine problems, sometimes a quadriceps palsy can be because of the spine problems. And the spine tuberculosis can give you a swelling in the medial aspect of the joint. That is a cold abscess. So spine examination is also must when you are dealing with the knee joint problems. So after this clinical examination, some of the important x-rays, when you see the x-ray AP and AP view, if you find there is a fleck of a bone that is the lateral aspect of the lateral tibial condyle, this is called Sigon sign. Sigon fracture is a very, very important. It classically says it is a 90 to 100% patient who will have injury to the anterior cruciate ligament, and these patients will have meniscal injuries and collateral ligament injuries. So very important, once it is there, it is sure that there is a anterior cruciate ligament injury is 90 to 100%. So that's why it is specific. And this is the arcuate sign. This is the head of the fibula is avulsion fracture from these. This indicates posterolateral corner injuries and posterior cruciate ligament injuries. Always you should check for this. So with this background, you should be able to make a diagnosis in knee problems. So with this, thank you, sir, for the patient listening.
Thank you very much, sir. It was very extensive.
Extensive, sir.
It's very, very extensive. As you said, good history is very important. You get a lot of clues regarding what we are going to see. And examination also, before we can sometimes ask the patient to localize, as you said, 70 to 80% diagnosis done. If you localize this, we will know the problem. Yeah. And with that history backing, we can know what is happening there. Yeah? And another thing I noticed that in the examinations, looking for scars is important. Sometimes they have history of surgery. Sometimes even the examiners don't see that. And when you notice it, and he gets very impressed, and he will come closer and look at it. Yeah, I didn't see that. Yeah, good. So that way you start on a positive note, and the examiner will be impressed. So have a good look. Usually the most of the male patients are hairy and they can miss the
scars. Are not visible.
Visible, and if you see them before the examiner sees, then he will be impressed. Yeah, so that's a good way to start. And also a common thing, as you sir said, common things, age group, you should know what are the common things in that age groups. Because as soon as you see the patient, you should be working in your brain. What am I looking at? You should be one step ahead and thinking. What am I going to find there, and what is the treatment? So you should be thinking that way. Yeah. And you should know common tests, like, common these days sports injuries like ACL injuries, sir said, very common, you should be very well versed with the Lachman's test, anti-drawer, and pivot shift test, And most of the tests, common tests, examiner tend to ask why it is positive, especially for the pivot shift test in the IT band going from the axis, going from back to front, that reduces the knee at 30 degrees of flexion.
30 degrees of flexion.
Like example I'm telling, so you should know, when you describe a test, you should know why it is positive, what is happening inside, so that the examiner knows that you are understanding the problem, why it is positive or why it is negative. And you should also develop a routine in practice, because we will not have that much time in clinical practice to do all these tests, So you should be able to have a quick routine to do 1 or 2 tests for each and quickly come to a probable diagnosis, especially when you start practicing in the clinics after getting the degree. So that's what I wanted to add. Thank you very much, sir. It was very, very excellent.
Sir.
Any questions? Hello, sir. Am I audible, sir?
Yeah,
sir,
audible.
You're audible, sir.
And another important
pivot shift test. Pivot shift test, sir, repeat.
Pivot shift test is testing for the anterior cruciate ligament and anterolateral instability. This is a very important 2 things you must remember. In pivot shift test, it is the test from the extension to flexion. That is the first point you remember. It is from the extension to flexion. So in the first thing, you hold the foot and internally rotate. So by doing the internal rotation, you are rotating the proximal part of the tibia. Lateral condyle is slipping anteriorly. So it is slipping anteriorly. And another hand you should keep at the level of the fibular head. And you apply the valgus force. Once you are applying the valgus force, you are further subluxating the tibia anteriorly. Once you are further subluxated tibia anteriorly, from extension to you try to bring back the foot to the normal position. Once you are doing the flexion, then automatically, normally the iliotibial tract, in complete extension, it will act like an extensor, and in 30 degrees of flexion, it acts like a flexor of the knee joint. This is the principle behind that. So that's why if iliotibial band is not working, this test will be negative. And MCL is also not working, this test will be negative. Why MCL is important? Where it is rotating, pivoting, the MCL is the pivoting structure. So MCL is holding the entire femoral condyle, and over the MCL, the tibial condyles are rotating. So the where it pivots, examiner sometimes asks, where it pivots, it is pivoting on the medial collateral ligament. So once you do it from extension to flexion, the iliotibial band, which is extensor, it becomes a flexor at the 30 degrees of flexion, and it pulls the tibial condyle downwards and it reduces. So once it is reduces, you will feel the and you will see. You can feel it and you can see it. Both the translation and reduction. Translation and reduction of the knee joint. So these are the 4 points always you must remember. Medial collateral ligament must be intact, iliotibial band must be intact, and at the same time you have to rotate it and you have to apply a valgus force. Then you do it from the extension to flexion. So this is called pivot shift test.
Another thing, sir, sometimes the patients are very apprehensive and it becomes a bit difficult to test the pivot test.
Yes.
Sir, yes, the same question I wanted to ask, sir.
Yeah.
So how many of these tests which you have described to us are very much practical in clinic? How many we have to do before surgery and after anesthesia?
Yeah, pivot shift test you can do when the patient is on the table, after the GE or spinal is given. Then you can elicit it very clearly. Yeah. Sometimes in the clinic, because of apprehension, you can't do properly. But on the table, you can very easily see that. Yeah, it's very obvious.
Then without giving any problem, there is another method. You hold the foot in your axilla and hold the proximal part of the leg. Then you elevate it. Then most of the times in a chronic cases, in a chronic ACL tears, definitely this pivot shift test is very easily positive. In acute cases, please don't try pivot shift test. It is not for the acute cases. For acute cases, Lachman is the best test and easily done. And even anterior drawer sign is also painful, but Lachman is painless and it is easily, you can do it. And it is more pathognomonic to say that it is a anterior cruciate ligament injury.
Yes. Yes. In acute stages, Lachman's is very reliable. Yes, sir.
Hello, anything
There is
about
So,
blondes and curvy?
Sir?
Anything you want to tell about blondes disease and curvy in knee joint?
So, blondes is infantile blondes, juvenile, and adult. It is from 2 up to 4 years, we will call it as infantile. From 4 to 8 years, it is called as juvenile. Beyond that, it is adult. So most of the times, any surgical contemplation, if you want to do, there is a classification, Langen scale classification is there. That thing, patient has to read it. There are classification. So any surgical intervention, most of the times, if you want to do it, it is better to do it before 4 years. That's why you will get very good results in blondes. So you have to identify it. But blondes, there are 3 components are there. Always you must see there is a varus, internal tibial torsion, and a procurvatum deformity. There are 3 components. Unlike other deformities, in a blondes, there are 3 deformities are in that. There is a varus deformity, internal tibial torsion, and a procurvatum of the tibia. So these are the 3 things always you must identify in a blondes case. So in a blondes case, most of the patients are obese. And it is most of the times it is unilateral first it is begin with. Sometimes it may be bilateral, but it is unilateral and it is predominantly because of the posteromedial defect of the tibia. Posteromedial defect, developmental defect of the tibia. So this is about blondes, sir.
No, clinically in pediatric age group,
Yes, sir.
in PTV, we will try to rule out when there is any varus or torsion is there.
So that is cover-up test. We have to do cover-up test, sir. So
Yes.
that what I explained. In the cover-up test, you close the distal part of the leg and you will see the proximal part of the leg, tibial tuberosity. So then you draw a Q angle. Then if the limb is in valgus, definitely it won't progress. It is only the varus deformity of that particular tibia. It is not progressing. It is not considered to be as a blondes. But if it is in a neutral position or in a varus, definitely that you have to think of blondes and you have to follow the patient. This is a screening test. Cover-up test is a screening test. Sir, anything you want to add about the scurvy?
Curvy,
add,
sir. No.
Please
No,
add.
this is only for the PGs to know whenever they are examining a pediatric case. So varus deformity, you have to think of that also and examine.
Yes, sir.
Because it is radiologically more than the clinical.
Yes, sir.
For that only, what PG should know that any case of pediatric. So one more thing, in scurvy, anything you want to knee examination particular or only history?
History is more suggestive, sir.
Oh, yes.
And sometimes there is a subperiosteal bleeds. You will see the huge swellings around the knee joint. And you have to suspect that that is a subperiosteal bleed. And patient usually, it is a pseudoparalysis. These patients will present with a pseudoparalysis.
Usually they present with that pseudo.
Yes.
Nice presentation, sir. Thank you.
Sir, thank you, sir.
Sir, couple of questions in the chat box, sir.
Sir, the vastus medialis, phynogenetically, vastus medialis is the developmental muscle. This is very important, we must observe. So it appears first and disappears first. Both are things are there. So embryologically, vastus medialis appears first and disappears first. So that's why it is a developmental problem. It is an evolution thing, vastus medialis. But vastus medialis is a very important stabilizer of the patella. That thing we must remember this. That is the cause for that. And in Latchman test, can you explain what is? Okay.
Pettada?
Santosh.
Baby care.
Mute
Yes, sir. In the Latchman test, Doorstop mechanism means, suppose you take the anterior drawer test. So hip joint is in 45 degrees flexion and knee joint is 90 degrees flexion. So that means femoral condyles are seating over the tibial condyles. They are seating over the tibial condyles. Once you are doing the anterior translation, because for the posterior part of the meniscus never allow the tibia to translate anteriorly. Or sometimes any tear in the meniscus, it comes in between the femoral condyle and tibial condyle. So it never allow it to draw anteriorly. It never allow that proximal part of the tibia translate anteriorly. So that is the problem in anterior drawer test where doorstop mechanism is functioning. Door stopper means you see in the door, there are stoppers. There is a triangular piece that is kept it there. So because meniscus is appearing like a triangular piece, so that is blocking anterior translation. But in Latchman, you are keeping the tibia and femur in 30 degrees of flexion. So the posterior part of the meniscus is freely hanging. It is not coming in between the femoral condyles and tibial condyles. The femoral condyle is not giving any pressure over the tibial condyles. So proximal part of the tibia is freely floating. So that's why the doorstop effect is not coming in the Latchman test. That's why Latchman test is far superior than anterior drawer test. That is a pathognomonic test. Hope I cleared.
Sir, one more doubt, sir. Are screw home mechanism and locking mechanism both same, or should it be different, considered different parts of the same mechanism?
No. Screw home mechanism is nothing but locking of the knee joint. So locking means once from the flexion to extension, once you are doing it, there is a closed chain mechanism and open chain mechanism. I can say that in this way. So in a closed chain, that means when your foot is on the ground, once your foot is on the ground, tibia is not moving and your femur will go into the internal rotation. Once your femur is going into the internal rotation, indirectly you are doing that, the tibia is going into the external rotation. I hope you got it. This is closed. So once the foot is on, femur rotates internally. Once the foot is off, that means once you are lifting in a swing phase, what do? You have to extend the knee joint. That means the foot is in the air. So once you are doing the extension, what will happen? Because of the quadriceps function, the tibia rotates laterally. The femur is not rotating here, but tibia is rotating. Tibia is rotating laterally. This is called screw home mechanism. Once the tibia is rotated laterally, entire both the femoral and tibial articulation is completely closed. Once it is closed, there is a less energy is conserved by the taken by the quadriceps muscle. So because of this screw home mechanism, person can able to stand for the longer period because quadriceps is not functioning. Entire joint is locked and you can able to stand. So this is the importance of screw home mechanism. And what is the unlocking muscle? It is the popliteus that unlocks to get the flexion.
Kishore, any more questions? Kishore?
No, sir. Ante, sir. Ante.
Sir, Abdul sir, Sivanand sir, I think questions are done.
Okay.
So it was a great session, sir, as usual. So if you say it's fine, then we'll end, end the session, sir.
Okay. Thank you, Patil sir. Thank you, Abdul
Thank
sir.
you, sir. Thank you, sir. It was
Thank
great.
you. Thank you, sir. Thank you, everyone. Thank you, all the PGs.
Thank you.
We'll meet next week for the case discussion. Thank you.
Thank you, sir.
Thank you, sir. Right.